physical inactivity, previously identified if they're impaired glucose tolerance or impaired fasting glucose. So then there is a chance they are at high risk. If there is hypertension and hyperlipidemia, then there is high risk of having type 2 diabetes. So how carbohydrate metabolism takes place? Carbohydrates are metabolized in the body to glucose, and this glucose is then used up by CNS. Our brain uses the glucose, and this uptake by the brain is independent of insulin. It doesn't require insulin for that. Glucose is also taken up by muscles to produce energy, and muscles need insulin to do that. Glucose is stored in liver as glycogen and in adipose tissue as fat. Insulin is produced and stored by the beta cells of the pancreas. So what happens after the food is ingested? Blood glucose concentration rises, which stimulates the insulin release. Insulin in turn causes the increased glucose uptake by the tissues, increases glycogen formation, decreases the glycogen breakdown, increases lipid synthesis, and inhibit fatty acid breakdown to ketone body, promotes protein synthesis. In turn, the glucose levels of the blood glucose levels, they start falling. What happens in the fasting state? In fasting state, insulin release is inhibited. So your body realizes that there is no more glucose in the blood. So the blood glucose, as it starts falling, then the insulin release is inhibited, and hormones that produce the hormones which are responsible for increased production of the glucose in the blood, they are released from the body, like glucagon, epinephrine, growth hormone, glucocorticoids, thyroid hormone. There is glycogenolysis, so whatever glycogen was stored, it starts coming out of there, and it starts breaking down and it is converted into glucose. Gluconeogenesis, amino acids are transported from muscles to liver and they are converted to glucose. Triglycerides are broken down into free fatty acids as an alternative fuel source. So when you have glucose, the free fatty acids are used, and triglycerides are the ones which are broken down for it. So again, the same thing. Type 1 is absolute deficiency of insulin due to immune-mediated destruction. In rare cases, it's not due to immune-mediated. It can be called idiopathic. So we can see in this picture this insulin producing cells, the blood cells, insulin is being produced, and the cells, these beta cells, they are quite nicely arranged around the arteries, and they are capillaries, and they are producing the insulin. Over here, there's destruction of the insulin producing cells, and so no insulin is there in the blood. There are 4 stages in the development of type 1. Preclinical period with positive beta cell antibodies. There's just beta cell antibodies. They don't have symptoms. Then when 80 to 90% of beta cells are destroyed, we get a hyperglycemia phase. Then there is a transient remission where patients, they go into remission and they start producing a little bit of insulin, which they have, that starts working, and this is known as honeymoon phase. And after that, the 4th stage is the establishment of the diabetes. So we can see this is the beta cell mass, which is 100% at the time of the birth, and at time in years, as the year passes, because of the genetic predisposition and immunological abnormalities, we start seeing a fall in this mass. It is falling, the mass is falling down, but still the beta mass is going down, but still the normal insulin is being released, and patient remains asymptomatic without any problem. He goes on in life. That is the point. 80 to 90% of when beta cells are gone, then the symptoms start appearing. But after appearing the symptoms for some time, some patients, they develop a honeymoon period. So some kind of reserved beta cells, they start functioning, and then therefore people don't have these symptoms. This can last for a year or two, 6 months or a year or two, and then after this, overt diabetes. So 90% of the mass is lost. So when type 1 diabetics are discovered, when they are presenting with diabetic ketoacidosis or with any symptoms, their 80 to 90% beta cell mass is gone. So they are completely, they'll need the treatment at any cost. They have to be started on treatment. Type 2, presence of both insulin resistance, insensitivity, and some degree of deficiency or beta cell dysfunction. It occurs when a diabetogenic lifestyle, excessive calories and intake is too much, eats too much, inadequate and inadequate calorie expenditure, meaning no exercise, sedentary lifestyle, and obesity, the weight gain, is superimposed on a susceptible genotype. So there is a genotype which is running in the family, so this gene is over there, and then person is not having good lifestyle, he is sedentary, he eats a lot of fast food, and he's obese, he's getting obese, so he will develop type 2 diabetes. So insulin resistance will be there. It is develops. Patient has initially has obesity, pre-diabetes, diabetes, and then uncontrolled diabetes, hyperglycemia. So patients start developing insulin resistance, and with this insulin resistance he starts having macrovascular diseases. So 0 is the point when you have discovered the patient has diabetes, and this is the time when he doesn't know that he has diabetes. So you can see the insulin resistance is still there 5 years before he has been discovered as having diabetes, and he has developed the macrovascular diseases. Beta cell initially with insulin resistant beta cell failure is not there, they are there, and this starts at the time of diagnosis. They start having the failure of the beta cells, and when there is failure after 15 to 20 to 25 years of having the disease, the insulin level starts declining. That's the time when we start giving them the insulin, and you can see as the beta cell go down, the post meal glucose start coming up, and it's the fasting in glucose which starts coming up a little later than the post meal ones, and this is the time when microvascular diseases start affecting and developing in these patients. So what are the lab tests? Glucosuria, to detect the glucose in the urine by a paper strip. It's a semi-quantitative and it depends on the normal kidney threshold for glucose. If the kidney has some defect, is already diseased, so then this cannot be much of use. Ketonuria is to detect ketone bodies in urine by a paper strip. It is again a semi-quantitative test. Then the much better to do to test for ketones is ketonemia, that is the test for ketones in the blood, because there are three types of the ketones which are present in the blood in the body, and amino is the acetoacetic drug is the one which goes into the urine. Beta hydroxybutyrate is the one which remains inside the blood, remains in the blood and is not excreted in the urine. So beta hydroxybutyrate is converted to acetoacid acid, and then sometimes if you don't have ketonuria, if the ketonuria has settled down, you have to check the blood, because the beta hydroxybutyrate might still be there and patient might still be in ketonemia. So ketonuria will tell about you about ketone, the amino acidic acetoacetic acid in the or the acetone in the urine. It will not tell you about the true ketone levels. True ketone levels will be detected by doing the blood sample and looking for ketonemia. Fasting blood glucose, glucose blood concentration in samples obtained after at least 8 hours of the last meal. So you have to do 8 hours of the last fasting. 8 hours fasting is must for a fasting blood glucose. Random blood glucose is a glucose blood concentration in samples obtained at any time regardless the time of the last meal. So whenever you take the blood, regardless of the last meal. For fasting, it has to be 8 hours of fast. Glucose tolerance test is the most accurate test for glucose utilization, especially in the patients who have borderline levels, fasting levels. What we do is give a 75 gram of glucose to the patient with 300 ml of water after an overnight fast, and samples are drawn at 1, 2, and 3 hours after taking the glucose. HbA1c or glycosylated hemoglobin is formed by condensation of glucose with free amino groups of globin component of hemoglobin. It comprises 4 to 6% of total hemoglobin. Increase in glucose blood concentration increases this hemoglobin fraction. HbA1c reflects the glycemic state during the preceding 8 to 12 weeks or 2 to 3 months. So जो patients कहते हैं ना 3 महीने की शुगर जो चेक करता है टेस्ट वो ये वाला है HbA1c. Serum fructosamine is formed by glycosylation of serum protein, mainly albumin. And since serum albumin has shorter half-life than hemoglobin, so it is for 2 weeks. Normal is between 1.5 to 2.4 when serum albumin is 5 gram per dl. When is this done? It is done in patients whose hemoglobin level is not appropriate. So someone with anemias, iron deficiency anemia, will have low hemoglobin, so the HbA1c will not be accurate. So their fasting sugars will be high, but they will be having low HbA1c, and we will be misdirected that patient doesn't have diabetes or his diabetes is controlled. In fact, the patient is having anemia. This can be iron deficiency anemia or thalassemia. So in such cases, serum fructosamine helps uh, in follow-up of these patients. So self-monitoring is very important for the patients, because by self-monitoring is the process with which patient will understand his glucose levels, his insulin requirement, his diabetes. He will to know. This is one of the best practices which we have to advise the patients with the diabetes, and they have for strict glycemic control. So it's extremely useful for outpatient monitoring, especially for patients who need tight control. A portable battery-operated device that measures the color intensity produced from adding a drop of blood to the glucose oxidase paper strip. So we have paper strips, glucose oxidase. You might have seen, many of you have diabetic patients at home, your grandparents or your parents, you might have seen this. So you just prick your tip of the finger, put it on the strip, and the strip is then inserted into the glucometer, and the glucometer then measures the level. So this is how it is done. They prick the tip and this. So there are many such, One Touch, Aquacheck, Dex, Prestige, Precision. Many companies are there which are available for this, from which you can get these glucometers. They're very cheap, and we advise most of the patients to have this. Now the newer thing in this is the continuous glucose monitoring. Is a very fancy. There's a patch which has a sensor. It is placed on the forearm. Sorry. So it is placed on the forearm. So it continuously in the subcutaneous. So it continuously measures the glucose level, and it has a fancy this kind of a device with which the sensor transmits. So the sensor transmits the readings, and the device tells you. Now what is going on is there are several apps which you can download on your mobiles, and these sensors can be connected to those apps, and they will give you a continuous glucose monitoring. These CGMs have revolutionized the glucose monitoring. These can also be connected with the laptops or with the hospital management, and doctors in their hospitals can have a look at the patient's continuous glucose levels and can advise them about their treatment. It is very useful in type 1 diabetic patients or patients who have been put on insulin, so it plays a very important role. It is very, very helpful for them. So what's the diagnostic criteria for diabetes? Symptoms of diabetes plus casual plasma glucose concentration